Hi, everybody. Welcome or welcome back to most of you.
We're back.
Thank you for coming back. Thank you. All right, so I'm gonna get started. We're gonna just, in case anyone missed the first part of the last meeting, I'm gonna just remind everyone about the meeting. So welcome to the January 23rd non-controlled prescription drug work group technical discussion. This is the second of two meetings for today. Our agenda for today is to continue our technical discussion reviewing variables that could be reported for each non-CDS dispense recorded. And with that, David, is there anything that you wanted to share?
Thanks for asking, Anna. No, just a huge round of applause again for the work that you all are helping us with. So much appreciated. And let's go ahead and keep moving.
Thank you. All right, so as a reminder, for each variable that we're going to discuss, there's a set of questions we would like to ask the work groups. The first one is for our dispensers. What are the technical or policy considerations for reporting a field for each non-CDS dispense? For all of our providers, what fields provide the most utility in clinical decision-making? And then for the whole work group, what fields are essential for public health analysis or evaluation purposes? Now, as a reminder, the fields we're going to review are loosely based on the ASAP and NCPDP standards. And Kelly did such a great job with helping us with documentation last time. I'm going to ask her if she can continue helping us with that again today, or for this meeting. Great, thank you, Kelly. So as a reminder, we left off on the prescriber information. So again, the fields that are shaded in gray are the fields that are available, similar in both standards. So we've reviewed many of these fields so far, whether they're NPI or DEA suffix, and we've discussed the name and the potential phone number for the prescriber that could be reported for each non-CDS dispense. And then one of the fields is the XDEA number, and that's something that is very much specific to controlled substances, so we won't spend too much time on that. Is there any other comments about what information about the prescriber would be particularly helpful to collect for each non-CDS dispense based on these variables presented?
Anna, this is Kevin. Going to the XDEA number, you're probably aware that there was a recent ruling, a change on that, so you may not be getting that one in the near future.
Thank you for the reminder, Kevin.
It's Dan. I just want to add that having the phone number is not only convenient for ER doctors like me who see patients one-off, but patients go to different doctors for different things. And it may be helpful for the orthopedist to be able to speak to the internist or the cardiologist or vice versa, because patients do bounce around. So it's a convenience factor that can be useful if it's not too much trouble to add.
Kevin, could you clarify what you just said?
Excuse me, you caught me with my mouth full. So it was late December, early January when someone else is going to have to correct me. I believe it was out of the Secure 2.0 Act or possibly another DEA ruling that they're not requiring the XDEA number any longer, but they are requiring providers to undergo something like 8 hours of training. So that really opens up the prescribing for buprenorphine. That actually went into effect late last month or early this month. The training is, they mentioned a June date within that. So I'm paraphrasing some of this. I can pull up the specific act and I'll put it in the chat if I can find that.
Yeah, no, I'm aware. It's just this doesn't really apply to the DEA number.
No, just the XDEA.
It only requires to the XDEA number, which is a
Correct.
separate field.
Correct.
Okay, Kelly, it's a little bit farther. It's right after phone number. Yeah, that's the field we're talking about. Thank you. So I'm hearing that phone number for the prescriber will be particularly helpful for care coordination. Is that something that pharmacies often have that could be reported? Bill, is this something that Express Scripts has for most prescriptions?
Yeah, we actually can't process a prescription we don't have a phone number. I will say though that if it's an institutional phone number, it may not be of much use.
So kind of similar to the conversation we had before about pharmacy phone numbers, the phone number associated with the clinic or maybe where the prescriber works is most helpful. And is that right? Or do others have thoughts on what would be the most helpful number to put for a prescriber?
Take any number you can get. Absolutely correct. You may get an institution number, you may get a prescriber's office, but you take whatever you can get and work backwards.
How do we feel about dummy phone numbers? Just want to put that out there that I know NCPDP has certain rules about putting in like all fives, all ones, things like that. Are we going to allow dummy phone numbers? Sorry, this is Karen Guinan from Wegmans.
So, Karen, I don't know if there's much value in doing that.
There isn't, and that's why I mean, do we want to make sure that we put something in here saying don't allow that? Because there isn't any value to it.
Yeah, I think that's definitely worth capturing, but it almost sounds like from what we heard a few minutes ago, in some instances, in order for the pharmacy to accept it, there has to be some value, some numeric value in that field.
Right. So a lot of times what happens is somebody will put in a number just to be able to process, but it does nothing. Nobody ever goes back and puts in a
accurate number.
Correct.
Good to know.
Kevin, in your experience, is there a QI process to confirm that it's an accurate number?
No, it tends to be a bit of a challenge sometimes with phone numbers. We may get it, but depending on, it happens. I remember when I used to be a real pharmacist, there used to be a challenge of reading, writing, which is not much of a problem as much anymore, but trying to figure out if you have 6 providers in a clinic and you can't read the writing and you don't call the clinic to find out, you may just choose the one that looks the closest. So you may actually have the wrong person, or if they have the DEA number and their name, which location is it? Is it at a location with that phone number that is associated with that DEA number, but that prescriber may have multiple DEA numbers and different phone numbers, or even if you were using the NPI and an associated phone number, is that provider using a home phone number versus a cell versus an office number?
Interesting. So if the data are matched to another data set like NPI, being cognizant that the information may have to, that it may be a personal phone number.
We've seen that.
Hey, Anna, this is Sharon from CBS, along those same lines, right? So a pharmacy system may take the prescriber identifier that comes in on the ERX, and then we match it to our own internal prescriber data file. And so the phone numbers come off of that prescriber data file.
That's helpful. Thanks, Sharon. So it may not need to be on every prescription. If you have your own database, that could be that information can come from.
Well, it just kind of adds to that complexity and that variation, right? Right, you've got all of these data sets out there, and it's a matter of putting the right connection points together.
And I believe the last variable in this prescriber section is, I believe, one from ASAP, and it's the jurisdiction or state issuing the prescriber license number, or to where the prescriber is licensed. Is this information that is readily available on prescriptions? Is this something that pharmacies would know? In addition to, would it be helpful for clinical decision making?
Did we discuss whether the prescriber license is useful? Because the way this works is a state that is requiring that the license number of the prescriber be reported.
Mm-hmm.
This field is to identify the state of that license. Now, you know the prescriber state because, well, hopefully you do, because the prescriber address is on the prescription. And so, but if it's, let's say you're on a border and the prescriber is in West Virginia and the patient is in Ohio, we're reporting that to the Ohio PMP, not the West Virginia PMP. But if Ohio were requiring the license number, then if all we report is the license number and they look in Ohio, that wouldn't be a valid license. And so we would have to be able to identify that the prescriber is from West Virginia. I don't see the value of the prescriber license in this exercise. And so I don't know that this is an issue, but that's what the purpose of the field is.
Okay. I'm wondering if it's an option similar to MPI or DEA where, you collect options based on what's available to the pharmacy to report, and with one of them, you're able to match an identifier with the prescriber. I don't know, Kevin, if the jurisdiction that the prescriber is licensed in is a helpful field in Nebraska.
We really haven't been utilizing it. It may help if you have, let's say, 2 Jim Smith and trying to narrow down where they're from.
Thank you.
I apologize. This is Karen Guiding from Wegmans. I wasn't on the earlier call, but for the cases where prescriber doesn't have a DEA, they don't have an MPI, what are you having? I know that in some states, in lieu of an MPI or a DEA, the state license is being submitted instead. Has that been addressed for this?
But I guess the question, Karen, would be how often does a prescriber not have an MPI number?
For veterinarians, they don't.
So is there an expectation for non-human prescription data to be reported here?
Well, if it's a gabapentin or something like that, I would assume they'd want that reported.
So these are interesting questions. I think for the moment, we don't have to get too bogged down in this because what we're sort of thinking on the non-CDS is that it's information that a healthcare provider can use in the course of treating a patient. And so I think to the point of veterinary medicine, that's important to know on the dispensing piece, but I'm not sure we want to get too bogged down in that just yet, because it's a policy question that's come up before, and it's a really good point. But I think for now we can note it as an item of a sort of a parking lot item in the notes here, and we'll come back to it as we get towards the end. But great point, and thank you for raising that.
Well, just a question then. So I understand that a lot of this is, well, this is going to be fed into what providers are going to be looking at to treat human patients, but there's going to be a record that's going to be used for the PMP, correct?
For the prescription drug monitoring program, or do you mean when you, I'm not sure I heard.
I mean, is there going to be one record that's going to be feeding both the PMP and CRISP? One
Well,
PMP?
so on the technical piece, that remains to be seen. There could be two different technology vendors that provide data in which then CRISP would use to integrate that into a display or a dashboard or a push back into an EHR. So those are what we're doing here, is trying to sift through all the elements to formulate what a technical proposal might look like for any vendor who chooses to competitively bid on the services.
So there's still the possibility that there could be one that could feed both.
It is a possibility.
So that's why I'm bringing this kind of stuff up, because it still is kind of important that we look at what.
So you're saying, so I think what you're saying, that's a good point. And again, I think we have to take this back and really think about it. If it's the same vendor that's used today, if there were a bid and competitively this panel selected the same vendor, you're saying that there would probably be an expansion of an existing record in terms of reporting.
Right, because one's going to feed just the PMP, one's going to feed CRISP. We need to make sure that we're not going to hurt the existing PMP.
Yeah, no, that's a very good point. Note to the team here. We'll keep that under watchful eye. Very good.
Okay.
Thank you.
And from CRISP's perspective, I just wanted to say that kind of regardless of how we get the data, we'll have to consider how we do integrate this data with the PMP or not, regardless of how it's collected.
Okay.
Great point.
Sorry. Okay. Sorry. Didn't mean to digress there,
No,
but
this is good. It keeps us focused. It's easy to
Kevin,
get
are you still on? Did Kevin
I
not
am.
join back?
Nope,
Okay.
I'm on.
You can probably speak to this because Nebraska, we report everything in one report, controls and non-controls.
Correct.
And just a reminder to the group that one of the clauses in the law is this is not going to be a significant expense to the reporting pharmacies.
Yeah, no,
And
that's exactly right.
Anything other than reporting everything in the same manner is going to be a significant expense for us.
That's a fair point. It's a fair point to raise. And again, not to go too far off the beaten path, we have heard that previously, and we understand those concerns.
And this is Sharon from CVS, just to kind of add to that, right? So I'm trying to figure out on the pharmacy side, do I need to, well, I have to be expected to report controlled substance data to the current PDMP, and then report that same data along with every other non-controlled prescription claim to CRISP.
Yeah, so these are good points, and I fear that we could easily go too far astray on what we're trying to do here at the moment. So we recognize these concerns. We've heard them. They have not fallen on deaf ears. We have to come back to them. But if we can get through this process, then we can move on to the next step of making sure that those kinds of concerns are appropriately addressed in an RFP. Because you're exactly right. This cannot create greater work for the dispensers, and nor can it create greater cost. But there are many opportunities around technology to make sure that, by way of example, this could be implemented in a transparent manner to the current dispensers through their existing reporting structure. So we'll work on the technical side, and we appreciate it, and we'll come back to it. But for now, I think we would be better served if we can just get through the specification piece.
All right, thank you, everybody. So with that, if there is nothing else to add to the prescriber segment, then we're going to move to the insurance segment. Is there anything else to add?
The only thing I can think of adding with prescriber segment is the prescriber address, and that just helps to align with the Support Act. If you are, and it might be more on the PDMP side, but prescriber location is one of the criteria being asked for by CMS when querying a PDMP. So somehow you may want to be able to identify the prescriber's location. And that's been addressed in the new ASAP version, but prior to that, it's just something you may want to consider including.
Today,
So,
don't they just use the excuse me, I'm sorry, the address that's associated with the NPI?
It's probably up to each PDMP on what external source they're using, NPI or DEA for that address.
Okay, I just know in Ohio, when you select a prescriber, it gives you the information, and I think it comes from the NPI.
that was exactly what I was going to say, though, that it could potentially come from a different source. So thank you. All right, so our next segment, the next several is insurance, claims, and pricing. And so these fields are not ASAP fields, but they're NCPDP. From, I believe, one of the latest standards. Leanne or Sharon, you may be able to keep me honest to that if that's not true. So let's start with the insurance segment, and then for each dispense, how readily available is it to report cardholder ID, first name, and last name?
So Anna, my first question is why would any of this insurance detail be needed for this clinical reporting? First of all, so it creates a risk because I guess it doesn't really matter because you're reporting the clinical data, but this is part of PHI, right? And the cardholder IDs and I just don't see why this level of detail is important or how it would be used.
That's helpful, Sharon. Are there public health potential considerations to take into account with some of this insurance data?
Just to add to that, you know, while they're thinking of that question, the cardholder IDs are proprietary to that individual insurance company's algorithm. Unless it's Medicare, then it's the MBI, Medicare Beneficiary ID.
It might be helpful for patient matching, maybe, but
Leanne, where I was going to go with that, if they wanted to use another attribute for patient matching, I would recommend that the submitter of the data send their internal ID.
But that ID, that internal ID might work within a chain of, let's say, CVS, but it would not be the same ID that would be used in a Walgreens or a Costco or whatever. So
today I could have insurance with Caremark and I have an ID with Caremark, but then tomorrow or February 1st, my insurance changes and it's with a different plan. I go to Optum, United Health, and I have a totally different ID. So you get the same variables happening there.
Yeah.
At least if you're using the submitter's internal ID, that should be pretty stagnant.
And in public health, it could just be information on whether somebody's insured or has prescription drug coverage, etc.
I personally, I don't feel comfortable sending that information.
Agreed.
I would agree with you, but that's the only use that I can think of would be maybe for patient matching or public health.
Yeah, I don't see the relevance to the purpose of the legislation.
And is that the same case for plan ID?
I would say it's pretty much the same for all of the insurance information.
Is it, just to clarify, is it that you collect it, but you don't think it has any value, or that it's not collected and it would be onerous to collect? I just want to make sure I'm.
Well, no, it's collected because if you're billing the prescription on insurance, you have to have this information, although not all of that information is relevant or or included, like you may or may not have a group number. You may or may not have a plan number. Eligibility clarification code, yeah. Medigap ID, Medicaid indicator, those type of things are just used in adjudication for the most part.
Yep, and those last three aren't even used probably.
Yeah.
So.
And on the clinical decision making, the only thing that I can see on this type, on the side of the prescriber, is if you're trying to get an underserved patient or an uninsured patient a medication, that, okay, you can use a wonderful new drug that's advertised on TV all the time, or a generic that probably works. They might better be able to afford it, but that's the conversation I think the prescriber would have, and would not, with the patient themselves, and not trust or look at this data to make that decision.
And some of this information would come from other fields that are already being reported, such as the payer type, the individual.
Right.
Yeah, so.
Well, I mean, Dave, that's all you would get is the payer type, right? We're not, I mean, there is no other section here that's giving you the insurance information, right? Like the BIN, the PCN, right? All of that information that we submit for the claim adjudication process. Because I don't see how that information is relevant from clinical review perspective.
Because it also doesn't identify the insurer, just the cardholder ID.
Yeah, I mean, I think you bring to light a good point, because I'm not hearing that there's a clinical utility from the provider standpoint, physician standpoint. And you're also saying the utility of it for public health purposes doesn't really appear to be all that significant. In fact, it may actually just be the data that's collected and not able to use it now or anytime in the near future. So
Agreed.
I think we can just mark these sections, Anna, with that comment, because I think those are very good points. If it's specifically for insurance purposes, not so useful.
One comment that might add a light. When there in the previous call, there are a number of discussion items that reference back to when an ICD code might be used, or when a SNOMED code might be used in relation. The insurance information allows a retrospective look at exactly who paid if and when claims data is then available. So you will, though you will, like in the previous conversation, get multiple codes for the same diagnosis between similar patients, or even same patient with different doctors. The insurance information is absolute after the payment is done. So without the insurance information, you won't be able to reconcile backwards to see things like who was the actual payer, what was the actual amounts paid, what were those amounts paid for. It is a we'll call it a reconcilable clinical use for the insurance information. And that is when after transactions are done, all the adjudication is made, and that would even include reversals when a transaction might have been submitted but then reversed. So,
Yes,
I just want
The
to
bananas and put it in it's about ready to go off.
so
Oh,
Stanley, I think your comments are good. I think if folks could just be mindful, if you're not talking, keep yourself on mute. We're picking up some background noise. Sorry, guys. Thank you. So Stanley, I think you bring to light a very good point, but there's an administrative side to this, but we want to kind of distance ourselves a bit from the administrative side. Are you saying there's a public health consideration in there, or?
Yeah, clinically, when you see a paid claim,
Right.
that paid claim to be made, you have to have an ICD code associated with it.
Understand, but paid meaning for treatment purposes or paid meaning for reconciliation of the operations?
Paid for treatment, which treatment and reconciliation become one and the same.
I don't believe that's true for pharmacy.
I would agree with that.
Yeah, I can pull up, we have 7 billion pharmacy claims. I can show you the claims data, and then you see the cross correlation. And in that case, when we talked about PC and bin combinations as an example, that becomes an area where it's almost 30–40% error rate, because if you're looking at a secondary payer PC and bin, it doesn't give you much of anything because you might just have a coupon or co-payment or something like that.
Right.
So,
And
this is Kathy Graff. If
Go
I
ahead.
could, I'm getting confused because I thought that this was for clinical purposes. There will be many, encounters reported that are self-pay, that it can't be required fields. And I think that it's just seems to be administrative information or financial information, and I'm not sure that's appropriate in this database.
yeah, other comments?
Yeah, I can just tell you that we don't even collect ICD-10 code information for about 99% of the prescriptions we process. We definitely don't transmit it on a pharmacy claim.
Yeah, understood. So let's just turn to our physician colleagues, our friends here. Dr. Morheim, Dr. McCree, any thoughts here?
David, I just wanted to say one thing. I don't think that, I mean, I think that we need that financial information actually is critical with clinical decision-making, because we have to look at more than just, healthcare is not only transactional. And so I think that it's, if we're looking to create something, that information that includes information about the patient, or where inferences can be made about the patient, I think are not insignificant in clinical decision making.
Interesting.
And yeah, that goes for public health too, David. I'm sorry to interrupt you again, but that goes to the public health side of it too, because one of the other things in the previous discussion that I was debating whether to say or not is that, the group of doctors that don't use the EHR, because the prescribers are group is very different than the dispensing group, right? So many doctors don't use electronic health records. Part of it is due to obviously bandwidth. Others is they're not familiar, they don't like using it. Others, instructions are in a language, English or Spanish, that they don't speak, and their patients are similar. And so if you're looking at public health considerations for, let's say, all the providers that are prescriptions that came in as written instead of electronic, that might be, reveal something, right? So I don't think, I think if we're creating something, we're trying to tack on to something, different story, but we're trying to create something that can have clinical utility, then I don't think we should discount patient attributes.
But I think that, thank you, Dr. McCree. That's
so I think it's helpful too, but I don't think it's, the most important thing. I wouldn't want the program to live or die on this. But the other thing I want to mention is that it seems to me this information is really essential for accurate patient identification. And also that it needs to be national. I'm in California at the moment. So, what happens if I go to the hospital here or see a doctor? They want to know that I have this information. So it's not just unique information unique within Maryland, but unique within, the nation, because people travel. And that's just an overall comment on this. So I think it's helpful to have it, as Dr. Macri just said, But I wouldn't want the program to live or die on having this. Yeah, I mean, if we could roll out in phases, and this is a secondary phase, but the key part of this is that we have accurate patient identification. And I know that the John Jones that I'm dealing with is that particular John Jones and not some other one.
And just to clarify, thank you, Dr. Mulheim. Are there some of the pharmacy dispensers that are saying this is not something that could be reported, or is it that it was just a preference that it's not be reported?
Hi, David, this is Sharon from CBS. I'd probably have to validate with our legal department and privacy and security if it's something that we could provide.
Understood.
And again, these attributes here, I don't think are going to get what, Dr. McCree and Dr. Morham have been, indicating would be beneficial from a clinical perspective. I don't think these fields here are going to give them that. It doesn't give them enough information. And as far as the financial information on the claim, that's a huge concern, because this was not portrayed as a financial database, and putting in the financial amounts associated to a claim opens up a whole new can of worms. There are tools available within the industry. So there is a standard called real-time pharmacy benefit, where physicians are able to obtain from the actual pharmacy benefit program what the patient's out-of-pocket cost would be for medication.
Okay.
I will just tack onto that prescription pricing information is proprietary. And I couldn't imagine the large chains / mail order pharmacies sharing that information with a public database.
Yeah, I hear you. So let's just Kelly, if you want to just mark these fields as such, and let's continue onward. I think we have more than enough information here. Anna, back to you.
Yeah. Our next segment is the claim segment, and then following that is pricing. So,
And in looking at this, I don't think that there's really anything more. This is all about claim adjudication, to where you should already have the information about the drug in the, in the NDC number, in the previous fields that we've talked about. Your prescription origin code is there. The only thing that you might have might be a DAW code. But the rest of kind of what you see there is related to what the payer needs to know to pay the claim.
Is the prescription number somewhere else in the layout? Because I think that's important.
there was a prescription number in the prescription field. I think it was the first one, and we talked about it on the 13th. Mm-hmm.
Oh, the way I'm understanding you've looked at multiple formats to create this tool that we're looking at. And so there may be some duplication of fields or the same data reported in a different field name. So we should be cautious when we go through this, that if we see duplication. Is that fair? There's some duplication because you consolidated other data formats. Okay.
Yeah, I tried my best to get it down, but no, thank you for calling that out. Appreciate it.
So is it then the group's determination that the elements listed here, except the one field, are more claims adjudication, and we don't need to, or we shouldn't spend too much time with them?
I would agree with that. The rest of the fields in here, David, are except for DAW and prescription origin code. All of the other ones are override type fields. So if something happened during the adjudication process where additional communication is going back and forth between the pharmacy and the payer.
Yeah, and the prescription origin code is what we were talking about, whether it was electronically prescribed or phoned in or faxed. So that field is already there.
So, okay, so we don't, and Anna or Kelly, you can take that out because it's already it's captured elsewhere. And then we can just mark these other fields unless there's someone else on the recall that thinks we should, we need to discuss any of these. Okay, Anna, back to you.
Thank you. All right, so then our last segment is the pricing segment. So this is the pricing information for each non-CDS dispenser.
Yeah, similar to our previous discussion, don't believe it belongs there. And these are the submitted values, which could be anything, right? It provides no relevance.
Right.
Because remember that the payer is responding with pricing information, which is based upon the
Contract.
agreement they have with the pharmacy, not what's submitted, but what is returned.
That's right. That's right. So from the clinician standpoint, just want to make sure we clarify. Dr. McCree, Dr. Moorheim.
I agree this is not relevant for clinical decision making.
Okay. Just mark them as such. And that would apply to all these down through at least 177. And including 177. Thank you. Well, that made short work of these areas.
Thank you all for your input. You know, we've gone pretty thoroughly through all of these variables, and you've shed a lot of light on considerations, whether it's reporting or clinical utility in them. We're going to clean up this document and reshare it with the group. So if there's anything else that you wanted to contribute to it, or that like wasn't represented accurately, we can revise that. But this has been incredibly helpful. I'm going to switch back to the slide deck here.
I just have one question. This is Kathy Graff again. Since you have used formats from various standards or layouts in order to come up with this superset that we've just gone through, has that information been provided to this group? In other words, did you use the electronic prescription layout? Did you use the obviously use the claim layout here? Did you use the I'm just wondering if there's a layout maybe you should have looked at that you didn't, and it would be helpful to know what you did look at, if you can provide that information later on.
Well, Anna, you want to?
I can definitely share which NCPDP layout I looked at. It was the ASAP, not the latest version, right, Kevin, but maybe 4.2B that I had built that Excel file off of, and I can share which NCPDP layout I had used to provide that information. But if there are other standards that definitely I may have missed something, would love your input on that.
Yeah, and we'd like to know if you don't think we've captured enough, because we understand that NCPDP and ASAP are the two standards used by and large. So if there's something that you think we ought to look at that we didn't, help us understand why. But the only concern we might have is that would it create a burden to the dispensers if we brought in a different standard altogether that they're used to reporting?
Sure, it's just hard to figure out what's missing. It's easier to, just comment on what you've got here, but it's a little harder to figure out what might be missing.
Yeah, and I think I would say that's a very good point. And we'll, in the spirit of transparency, we'll make sure you know exactly what we looked at. But I think from the clinician standpoint, we want to make sure that the clinicians can say to us, once we get to this point, that we think they'll be getting enough information that will help them to provide the care that would best serve the patients that's in front of them and manage those patients' care. And if we can say we're doing that and the list isn't 100%, then the physicians might say, hey, well, it's 100% to us. And I think that's an important step to us, is to make sure the providers find utility in whatever we're getting to them. And
Thank you, David, for emphasizing that. That's the big picture. And I know we're working through the details to get back to the big picture and take the credit or the blame for being the original sponsor of the legislation that created all of this. But it really just comes from having to do clinical decision making and wanting, and especially as, the world of pharmaceuticals has expanded greatly into all kinds of new medicines and side effects and drug-drug interactions. You just have to know what people are taking to manage them now. And this is really helpful. I like to thank everybody for participating. In the end, it should be, accurate, national, and real time. That's basically what the clinicians want. And I assume it will go through CRISP or the state health information exchange so that it's in the format and the location where we're used to looking at things anyways. What the clinicians don't want to have to do is log in and log out. What they want to see is another tab, just like we're working on another set of, with advanced directives based on legislation, that there'll be an advanced directive tabs, there'll be a medication tabs, just like there are the other tabs. And how this is, I really think about is where does CRISP or the HIE or both, in effect, one and the same, get this information? How does it funnel through into CRISP? Then, to the various computers that all the clinicians are looking at, especially the hospital-based ones. Yes, there are physicians who are not connected, but that's a smaller and smaller group. But thank you. I really appreciate where we're going with this and the detail you're working through. But in the end, it's so that I can make informed decisions for patient care and the people that are in my role.
Yeah, and I think from the NHCC's perspective, we truly are indebted in many ways to the contribution, the intellectual contribution of everyone here. We tried, as Dr. Morheim noted, we've been working on initiative like this for a while, and it was Dr. Morheim in the legislature that really spurred us forward. And this has been a labor of love for many of us, and we're getting there. And the solution is supposed to be to the benefit of care delivery first, and then secondly, to public health in general.
You also might want to look at Ben Steffen's testimony on the bill that passed in 2022, because he also points out that I may have the number slightly off, but something like 8% to 10% of hospital admissions are medication related. You can reduce that number to, cut that in half. You've really saved a lot of people and a lot of money. Read my testimony too. It's in there. It's pretty good. But Ben really makes some very good points, I thought, on the implication, because clinicians, we're not always thinking of it. It's a medication reaction, medication issue. We go through all the other stuff first, but it's really high up on the list and needs to be emphasized. Thanks, David.
You bet. And for those of you who don't know, Mr. Steffen is our executive director of the Maryland Healthcare Commission. So from here, what this information will be used for is to help, once we get it refined, and everyone will get another opportunity or so to look at it, but it will be handed over to CRISP, who has been part of this work all along, and it will inform development of their competitive RFP process. But that is really the next step, is to create a more refined set of specifications and then vet it back with you all at least one more time. And maybe we do this independently or as a group, but it gives everybody a chance to weigh in with sort of fresh eyes and more opportunity to think about it. So that would be the next step, Anna. And if I'm misstating anything, please let me know. But I think there's also a question. I see a hand. I don't know if that's a new hand up or an old hand. Sharon, are you wishing to comment?
Yeah, thank you, David. So I may be getting a little ahead of myself here. I tend to boil the ocean quite often. But curious if there's been any discussions or thoughts around incorporating patient supply data, considering some of the other regulations that have been put in place with the mandates with patient portals, and there's so much opportunity within that realm for patients to report. Let's say that they are taking over-the-counter medications, right? The pharmacy may not know that. If it's not billed to their insurance, we don't know what they're purchasing, off the shelves, or any homeopathic type therapy that eventually could supplement the clinical review.
Yeah, your thinking is spot on. In fact, we've been working here at MHCC, Nikki Majewski, Justine Springer, Kelly Scott, and Anna Gribble, and others. These are just people I see on the call, to really look at how patient-generated health data can be incorporated into the clinical perspective, the utility for fabulous individuals providing care, Dr. Morheim, Dr. McCree, there's many others here on the call as well. And so dispensers have better information as they go about and do their work. It is sort of part of a roadmap, but it won't happen in this phase. Dr. Morheim mentioned maybe there's a second phase. Something like that is probably more to a third or fourth phase, because it's a long journey that we've been grappling with here in Maryland, but nationally there's some sort of shouldering of these kinds of efforts underway as well.
Thanks, David.
Sure.
All right, everyone. Well, thank you so much for all of your hard work and going through all these measures with us. As I said, I will combine your feedback and then also share which CPDP standard and ASAP standard was used to create this Excel file. We do have a meeting scheduled for January 30th at 10 a.m. More information about that meeting and the agenda to follow. But we just are very appreciative of everyone on the call, and especially 2 meetings in one day. Y'all are troopers. Thank you so much.
Thank you all.